Let's give a big shout out and welcome to Dr. Mosier from Honor Health Research Institute.
Welcome, everyone, and thanks for coming both in person and online. We saw most of you guys yesterday. I think we even have more in attendance today, which is great. Today, the talks are more kind of medically focused, so we actually have a really good lineup of people coming. We have a lot of different physicians and other people coming in to speak today, so it should be a pretty good discussion. Most of the discussions today will have slides to help guide it, but we really want these to be discussions. So if you have questions, raise your hand. Most of it will be a panel format, and so we really want this to be interactive so you guys can get the information that best serves you.
When we're talking about liver-directed therapy, there's two kind of ways that we can treat tumors in the liver. One are directly, sticking needles or probes into the liver to treat the tumors, and then there's also the transarterial approach that we can use, taking advantage of the liver's unique dual blood supply to allow us to treat tumors through the hepatic artery while letting the portal vein, which provides most of the blood flow to the liver, to kind of keep the liver alive. We'll kind of break this talk briefly into two subsets of ways to treat. So we'll first talk about the percutaneous treatments for liver tumors. The mainstay of this treatment for percutaneous therapy is ablation. It could be either heat-based or freezing-based, so cryoablation or either microwave radiofrequency ablation, where we're using temperature to create direct tissue damage and kill whatever is in the tumor with those temperature effects. The pros of this are its efficacy is similar to that of if you go in and have this surgically removed. The cons are it does require that it has to be a small, relatively small size, and we can only treat a certain amount based on the size and kind of the tissue destruction that we cause. One thing that we also participate in is clinical trials where we're doing intratumoral injection, where we directly inject whatever medicine they come up with for us directly into the tumor to try and induce an immune response or kind of affect it directly into the tumor itself. So that's very well tolerated and very small needles, and it's very straightforward for us to get the medication inside the tumor, and that's kind of all done on a clinical trial basis. There are several. And then this is one of the new kind of cutting edge therapies that we're really excited about coming on is histotripsy. So this is an ultrasound-based technology where they give high frequency, high amplitude pulses that causes kind of direct vaporization of the tissue. But what's really exciting is it's completely non-invasive. So it's all done without any incision and very well tolerated just because there's no incision or anything, and it still allows you to treat tumors inside the liver. Those are the percutaneous options that we have. So other things that we can work through are transarterial approaches to treating these tumors. There are many different ways. There's not a ton of data on most of them. I don't really have experience with because this is done by the surgeons. They can implant a infusion catheter that directly infuses chemotherapy directly to the liver through a port just beneath the skin, and where you can have kind of weekly infusions to treat directly into the liver vasculature. One of the kind of mainstays of liver-directed therapy that we've had for many years is transarterial embolization. There are many, many different ways to do this. It can be what we call bland, so just kind of impeding the blood flow to the tumors, the embolic effect, or it can be combined with many different chemotherapy drugs to also deposit the chemotherapy directly into the liver tumors themselves. In the setting of uveal melanoma, there's not a lot of data to show which combination works best. And the biggest kind of downside of this procedure is it can be painful, just because we are intentionally cutting off the blood supply, so it can be quite painful if we're doing a large area of the liver. The other potential transarterial therapy is immunoembolization, where you try and induce an immune response by kind of directly infusing these medications, the granulocyte macrophage colony stimulating factor, directly into the liver to try and induce the immune response of the tumors. So I'm sure most of you maybe have heard of Y90 radioembolization. That's kind of the mainstay of treatment currently for a lot of liver-directed therapies. And what that is, it's a special radioisotope called yttrium-90 that we can directly inject to the liver. And what it does is it deposits either resin or glass microspheres directly into the tumor. They release radiation directly into those tumor cells that only penetrates about 2 millimeters. So we can give high doses of radiation directly to the liver without causing effects elsewhere in the body. With Y90, it's all about being able to get adequate dose to the tumor. So in general, this works better for kind of fewer number of lesions where we can really give high doses of radiation directly to the tumor. And it's actually quite well tolerated from a symptomatic standpoint as well. And then finally, one of the things that I'm very excited about, and a lot of us are very excited about, is percutaneous hepatic perfusion with the Hepzato kit. And so the principles of that are to saturate the whole liver with melphalan, with the chemotherapy agent, and then isolate all the blood flow return out of the liver to allow us to filter out the chemotherapy prior to giving the blood back to minimize the systemic toxicity of the chemotherapy agent. So that's one of the things we're very excited about that's shown good efficacy in liver metastases. So I have a couple cases here from Dr. Ma at Wisconsin, kind of showing the efficacy of, this was a Hepzato case, where you can see here, this is a large tumor in the liver here. You can see around here, and this is during the second cycle of the Hepzato treatment. You can see that it's much smaller even after one therapy. So there was also a corresponding decrease in the circulating tumor DNA.
I think that was a really good rundown about the different liver-directed options that are available. And like Dr. Lowe said, the great thing is there's a ton of options. The bad thing is we don't always have strong data about which is best. Obviously, Hepzato is the only FDA-approved liver-directed therapy specifically for uveal melanoma, so we do have really strong data for that. But in terms of ablations, histotripsy is approved for any liver metastasis, is that correct, Jason? So not necessarily uveal, but uveal goes to the liver, so it is approved in that regard. But immunoembolization, radioembolization, all of these things have data to support their use, but they've never really been compared head-to-head. So it can get very confusing as a patient to try to figure out, well, which one should I do? Because there's not great data, if you go see 4 different physicians, you might get 6 different answers. And that's because we don't necessarily always know what the best option is because there's just limited data in rare tumors. So I think that was a really great overview. And we'll start with Dr. Hadfield. When you're seeing a patient with uveal melanoma, obviously there's the systemic therapies that we have of Kimmtrak and the clinical trials that are going on with IDEA and Replimune and in Octura. But how do you approach a patient? When would you say, okay, I need to give this person systemic therapy, or when would you say liver-directed option may be best for this patient?
You know, that was a wonderful overview of liver-directed therapies, and I think when you're meeting patients for the first time, there's a few things to kind of keep in mind. Liver-directed therapies are often technically challenging in different ways. So, for instance, sometimes patients just aren't good candidates for procedures, and they may be more amenable to systemic therapy, and that's something to consider. One thing that does come up quite a bit in my clinic, and I'm not sure if this resonates with anyone here, but oftentimes when I talk about liver-directed therapy in conjunction with interventional radiology colleagues or surgical colleagues, one of the concerns is that when you treat something just in the liver, it's only going to have an effect in the liver, and I think now we're starting to see some data that if you treat liver-directed lesions, particularly with these immune agonists in clinical trials like the Replimune study, you can actually incite a more systemic immune response. And that's borne out with clinical data that's now becoming available. So I think it's certainly dependent on patient preference. Some patients don't want to undergo procedures and they're more comfortable with systemic therapies. But I think that's my general approach.
Okay, so to expound on that, when you're looking at someone with just only liver mets, I think liver-directed therapy is reasonable, but you're absolutely right. There is a chance that it can spread outside the liver, and obviously you're not going to be treating that. With uveal melanoma, sometimes the disease will stay in the liver for a couple of years. And I think a lot of the time, one of the things that can predict that is the volume of disease. So typically, if I see someone with a high volume of disease in the liver, that makes me wonder if we should be doing a liver-directed therapy but also systemic therapy at the same time, or planning to sequence them very quickly. I think in general, people with very limited disease in the liver typically are more likely to benefit from the liver-directed therapy long term, just because they're probably less likely to have it spread outside the liver. When we're differentiating, Jason did a really good job talking about the percutaneous stuff, where we stick a needle in and inject or treat 1 or 2 lesions, versus the embolizations and the more Hepzato, which treats the entire liver. Jason, would you want to comment on how you would look at on a scan to say, I can do this with a percutaneous ablation versus I need to treat the entire liver with Hepzato or an embolization or something like that?
That's a great question. The biggest thing is size and tumor number. If you have somebody that has 1, 2 metastases in the liver that are smaller than 3 centimeters as kind of our cutoff, then I think the approach would be to try and treat both of those with ablation, because we know we have data just in general with ablation that it can be roughly equivalent to having surgical resection. It's all about kind of number of tumor. Now, once you start getting multiple tumors, then you have to kind of start thinking of more distribution of the therapy, where you can kind of treat the liver in totality, because you can only treat 2 or 3 lesions with the percutaneous ablation technologies.
Yeah, that's a great question. So I'll just repeat it so everyone on Zoom can hear. With these local therapies, we can treat the disease in the liver, but as we've talked about, there's a chance it could spread outside. So is there any thought about trying to combine systemic and liver-directed therapies? We do that for some patients, just because if they have a high disease, a burden, we feel like the systemic therapy may not be strong enough to shrink it. So we'll give the liver-directed therapy with that. In terms of data, we are getting some data. So I think it's Kevin Kim at Sutter Health has done a clinical trial for a while combining Ipi/Nivo with radioembolization. I don't believe we've seen the full results from that. I know early on, if you did them both at the same time, that there's a little risk for toxicity, so staggering them out is probably a little bit better. There's also a couple of different clinical trials going on with Delcath right now in Europe, where they're combining both the Hepzato kit, so the percutaneous hepatic perfusion, with nivolumab and ipilimumab for patients with uveal melanoma. So people are looking at that. We don't have the data, but I think for the patients where you say, I need to treat stuff outside the liver, but also there's a lot of disease in the liver and I need to debulk it or shrink it because it's going to start causing side effects such as pain or other issues, doing the combination is a reasonable approach. But as everything in medicine, more may be better, but more also may be more toxic too. So we have to balance out all of those different things. But I'm really looking forward to some of those trials reading out to really show us if there's benefit and synergy between the two.
When cancer starts, it starts in one place. In terms of uveal melanoma, the cancer started in your eye. And then, unfortunately, as the cancer progresses, it figures out ways to hide from your immune system. Your immune system typically kills bacteria and viruses. It also kills cancer cells. And when the cancer figures out how to get around your immune system, it can then spread to other places. And that's typically through your lymphatics and your blood. And then it shows up as tumors in other parts of your body. Uveal melanoma specifically has the highest propensity to spread to your liver most of the time. But generally speaking, the cancer cells have started somewhere and they're then dispersed throughout your body. It's just you're seeing the tumor somewhere else. And that's why things like circulating tumor DNA, which is a biomarker of the tumor, is so important in the blood for many of these treatments. So there's this type of seed and soil thought about metastasis, cancer spreading. We don't have a great understanding of why some cancers spread to certain places and others not to different parts of the body, and that's still something we're kind of learning.
But I would love to get Dr. Ma's thoughts about, when looking at a patient who needs liver-directed therapy, how does he choose Hepzato versus an ablation or some of these other different local therapies that are out there?
I believe I heard from Dr. Moser about one of the case examples that we had displayed up there. What was interesting was we were one of the very few centers in the U.S. that had Hepzato available when it became FDA approved. We've treated a number of patients at this point. One of the case examples that we submitted or had displayed was a patient who we found actually had a pretty significant response to treatment after one cycle of therapy. This was actually our first patient, and so we were fortunate to actually have one of our interventional radiologists is able to obtain imagings at the time of the procedure. And so by the time the patient received their second dose or prior to their second dose of Hepzato, we were actually able to visualize how much their disease burden, the metastatic uveal melanoma burden in their liver, was able to shrink almost greater than 50% after a 6-week interval of therapy. And we're pleased to say that he continues to respond well to therapy and has received their 4th dose this past week. And so what's great, as opposed to some of the other systemic therapy options, is that with this being sort of a liver-directed therapy, he's actually had fairly minimal toxicities associated with it.
Great. Thanks for that, Vince. And in addition, we were discussing how to choose liver-directed therapies. And with your experience with the Hepzato kit, could you walk us through, when you look at a patient, what guides you to say, I think we should do an embolization or an ablation or a Hepzato? How do you choose the patients that you think would benefit most from Hepzato versus these other liver-directed therapies?
Yeah, that's a great question. Well, oftentimes, when I meet a patient with metastatic uveal melanoma in my clinic, we'll oftentimes review the imaging together and also discuss the case within a multidisciplinary tumor board setting. So we'll have specialists, including surgeons, radiation oncologists, and interventional radiology present at these tumor board, and we'll extensively review the imaging, particularly the liver. And at that point, we'll kind of assess, for example, how much disease involvement is there specifically in the liver. For cases where we're seeing maybe 1, maybe up to 5 lesions, where it is quite accessible by the surgeon, we'll oftentimes consider a resection of the disease by surgery. But for some cases where surgery may not be permissible and we want to take what we call a more palliative approach, less invasive, we'll sometimes consider just using radiation therapy alone. For cases where there's maybe multifocal disease, meaning that there's extensive disease involvement of the liver, we'll often at that point really think about using sort of PHP or percutaneous hepatic perfusion therapy with Hepzato. And one of the nice advantages of Hepzato is the ability to saturate or treat the entire liver with chemotherapy and melphalan. And in those cases, we'll also assess the patient's general candidacy for therapy. Because as of right now, the FDA approval for Hepzato is that less than 50% of the liver has to be involved by the disease itself. And we also have to make sure that there is no other sites of disease elsewhere outside the liver in order to be a candidate. But if there is disease outside the liver, we'll oftentimes need to consider definitive surgery or radiation. For example, if there's metastatic disease in the lungs, bones, or skins, those do need to be treated before consideration of Hepzato. But generally speaking, for liver-only disease, we'll definitely strongly consider liver-directed therapy. Generally speaking, because we know how extensive and how morbid liver involvement by cancer can be. And so it's important to really be aggressive with treating disease as much as possible. And especially for melanoma, where 90-95% of patients have a disease involving the liver at the time of stage 4 diagnosis. It's a significant cause for why patients overall decline and inevitably lead to death if the disease itself is not well managed quickly and efficiently.
Great. I think that was a great discussion. Any questions from the audience or any questions from the Zoom back in the back?
How rapidly can the cancer grow within the liver? So if someone is scanned every 6 months, month 1, they're clear. Month 6, could it be more than 50% of the liver involved with cancer?
Typically not. We know from the updated Kook 2.1 study, which Dr. Harbour will talk about in a pre-recorded lecture later today, that if you have uveal melanoma and you're getting scans, the median time to developing disease in the liver, it depends a little bit on your genetic risk, but the earliest is kind of 1.5 years, and sometimes it's up to 2.5 years. Now, obviously there's extremes. Have I seen people go from nothing to significant disease in 6 months? Yes, but that's very rare. Most of the time, if you have kind of intermediate or low risk, it's going to grow fairly slow. And so there won't be much change within 6 months. If you're high risk, most of us will do scans every 3 months after your treatment, although those guidelines are very soft, and so there's a lot of variability there, and so we wouldn't catch that. But it's very rare that someone's cancer grows that fast. unfortunately, the frank reality is if your cancer is growing that fast, that's a reflection of just how aggressive the cancer is. And it means that you're less likely to respond to the therapy. So a lot of people in those situations will think, oh, I should have done something different. I should have scanned sooner. But that may not have always changed anything, because at the end of the day, it was the cancer's aggressiveness, not something you did or your physician did or something like that. Okay, so I'll throw a question to Dr. Lowe then. So most of us these days are doing surveillance scans for patients who have treated uveal melanoma. So we are catching patients with liver metastases when they may have 1 or 2 liver metastases or very low disease burden. So when we're seeing these patients, a lot of times we consider them for liver-directed therapy. If a patient were to ask you and say, okay, of all the liver-directed therapies, ablation, embolization, either radio or immunoembolization or Hepzato, what are the side effects? And what do you think is kind of the most side effect one, or what is the easiest one to do? Just kind of help guide that discussion about what is it like for the patients to go through when we think they're a good candidate for any of these liver-directed therapies.
That's a really good point. They all do have their own kind of separate, unique side effects for each treatment. So if we're talking about ablation, first of all, in general, they do require the procedure to be done under general anesthesia. They often will require overnight admission to the hospital. They're generally well tolerated, but they can be painful. You can have discomfort from the ablation itself. And they do have an infection risk as well, just because we're destroying the area that we're either heating or cooling in the liver. Now, when we're talking about transarterial therapies, as I said, the chemoembolization or kind of the embolic technology or treatments, they tend to be painful just because we are intentionally blocking off the blood flow to whatever area of the liver we decide. So I tell patients that you will have pain, and we just have to do our best to manage that for the week or so it takes for your body to recover from that. Y90 is very well tolerated from a pain standpoint. The most common thing people have is kind of just a generalized flu-like illness. So just a few days of fatigue, nausea, things like that. Now, there are some serious side effects that can happen from Y90. You can get ulcerations in your stomach, intestines. You can get radiation fibrosis to your lungs. But those are things that we are very careful about not causing. And so that's why any Y90 we do actually has a procedure beforehand where we completely map out the blood flow to the liver and find any of those little arteries that could potentially go to the stomach that could cause problems. And we do actually quantify how much radiation will be given to the lungs as well during our planning phase. And with the Hepzato, we've seen that overall the systemic effects are quite mild. Most commonly, people will have some GI upset or nausea related to it. And that also requires an overnight admission to the hospital just for monitoring. And we can induce low platelets, different things in the blood profile that we require blood transfusions and things like that with the Hepzato as well.
So one of the treatments that's commonly used for early or low volume disease in the liver at a lot of centers around the US is immunoembolization, which is given kind of repetitively every 8 weeks for up to sometimes 6-10 treatments. Is there any risk to repetitively embolizing your liver every 2 months for that number of treatments, or do you typically see that it's well tolerated throughout?
So it's usually well tolerated, and given a few weeks separation, the liver recovers. The immunoembolization doesn't appear to have as toxic effects on the blood vessels. So whenever we're going in to do a transarterial treatment, when we look at the small blood vessels in the liver, if we do multiple of those procedures where we give the chemoembolization, that can really affect the blood vessels over time, but the immunoembolization doesn't seem to do that. So it allows us to kind of do this treatment repetitively. More so, the issue with repeated transarterial treatments is we start running out of access sites. So because we can only use the wrist or the arteries in the groin, so there's kind of we have to be judicious about where we're accessing for these procedures, just to kind of let the access arteries heal whenever we're kind of doing consecutive treatments over time.
Well, any last questions from the audience before we wrap this session up early? That's a great question. So just to repeat that for Zoom. So if we treat a lesion in the liver, does it go away on the scans, or is something still there? Most of the time we will see some shrinkage or some changes, but there will be something there. I think one of the things we've learned about uveal melanoma liver metastases in the past couple of years is that the way the liver heals, the scans never look like it's fully gone away. But if we do other tests like circulating tumor DNA, which we'll talk about later, or these other tests to say, is there cancer still in the body? We're finding that those may be more accurate for determining response, because the liver doesn't always shrink as much as we would expect. If you treat something in the lung, it tends to fully go away. We just don't see that in the liver. So usually there may be some shrinkage, but otherwise there's normally something there. Either it's scars, it becomes hollow and cystic, it just changes textures, it loses enhancement, but usually the scans don't completely go away.
I have a question, just based on, I've had a few patients reach out to me who've had recent treatment, and I actually was talking to Dr. Johnny John, which I don't see him in here, so we may not have him to defer to, but I was curious, procedurally, when we talk about immunoembolization and chemoembolization, like in Philly, where Dr. Sato and Dr. Orloff have performed that with Dr. Adamo, there's this period of time where you're required to lay on your back. Is that the case with Hepzato kit? Why or why not? Because I've heard mixed things from various different interventional radiology teams.
The short answer is yes. There will be a minimum kind of 3 hours that you'll be in bed with the Hepzato kit. And the biggest thing is the arterial access. Mm-hmm. So anytime you stick the artery, we put a little sheath in. And we have to be very careful, and we put people on bed rest. They can't bend their hip during that time, just because bleeding can occur, and you can get hematomas and things like that at the access site. So we're all, for the Hepzato, it's 4 access points. So it's both sides of the neck, both groin, an arterial and venous in the groin. So there is minimum 3 hours. We have devices we can use to plug up the hole in the artery, but that still requires 3 hours of bed rest minimum. Most people are about 6.
Yeah, I was going to say, I'm hearing a more common number is maybe about 6 hours of time. And is that going to kind of include some period of, I mean, I just know anesthesia. Let's pretend you're under anesthesia. That time counts as some of the time you're under, as long as the catheters have been removed?
That's a good question. So I'm counting it when we get all the catheters out. So this is still fairly new. And each patient we're finding is a little bit different in what they require from a blood product standpoint afterwards, whether they need platelets or plasma to correct any of the coagulopathies that need to be corrected before we can safely remove all those access points. So I think the more and more we do, the more we'll see, and the more we'll be able to kind of shrink that time frame down, where we can start. They have closure devices for veins that we can use to kind of minimize that time where people are kind of stuck in bed.
Yeah, and that makes sense too. The procedure would, as you go from new to doing the procedure to more seasoned, I suppose, that you would get faster, you'd get a little more efficient. The team kind of figures out the best ways to do everything. Anyway, I feel like that helps answer my question, that there is some level of you have to lay flat, even in Hepzato.
Any of the transarterial therapies, there will be a 3 to 6 hour bed rest afterwards, unless you go through the wrist, which you can do, but for Hepzato, you can't go through the wrist. Yeah.
Thank you so much, Dr. Lowe.
Great. So unless there's any other questions, we'll wrap up the session a couple of minutes early.
All right. Thank you, guys.